Put us all on mute and let everyone in. Hello, everyone, and welcome to today's virtual interactive panel discussion brought to you by Oregon Chapter of ACHE. My name is Tia, and I will be serving as your ACHE technical host for today. We are so glad that you are able to join us. Before we get started, I would like to go over a few items to help you navigate the program in our virtual environment. For the purposes of noise control, your lines will be muted for the duration of the session. The chat function will be available to you throughout the entire event. This event is being recorded and will be available for viewing in ACHE's learning management system in approximately 2 business days. Today's session is worth 1.5 hours of ACHE Virtual Interactive Education credit. To earn this credit, you must be logged in for the entire 90 minutes of this event. All attendees who meet this requirement will have their 1.5 Virtual Interactive Education credit applied within 2 weeks from today's event. We do encourage you to complete the evaluation. I'm going to drop the link in the chat box shortly, and then I will reshare it before we close out. Now to begin, let's turn it over to Valdez.
All right. Well, thank you so much, Tia, and thank you all so much for being here. Thanks for dialing into this awesome Oregon ACHE morning webinar on palliative care. My name is Valdez Bravo. I use he, him, his pronouns, and I am the president of Oregon ACHE. So again, thank you so much for making the time in your life for your professional development and learning about this topic, or maybe a refresher on this topic. We're just sharing the latest and greatest out of the palliative care world. We've got some talented moderator panelists today. We're very excited. So thank you for attending. Again, my name is Valdez Bravo, and my day job is Deputy Director at the Multnomah County Health Department. Multnomah County is the Oregon's largest, most populous county with a diverse community of over 800,000 residents distributed across over 465 square miles. I'm an Army veteran of 8 years and who continued my service at the VA for 18 years. And I have been active in ACHE since attending the Army Baylor graduate program. Got my mug. Actually, I'm drinking my coffee right now, my Army Baylor mug, sick and embarrassed. And Health and Business Administration, and I've been a board member of Oregon ACHE since 2019. So really excited to be here today with you all. And I will say this is my last learning event as chapter president. So I'm handing the reins off to Wing Chan, who is our president-elect, who will be starting on January 1st, 2025. Wing is going to be an awesome president because he's already been an awesome board member and secretary treasurer. So he's going to keep it up, and I'll be there as immediate past president. But so Oregon ACHE members, you'll still see my smiling face, maybe just not talking as much, which is probably a good thing. But anyway, thanks so much. It's been an honor to be your president for the past 2 years. And again, super excited to go out with this palliative care awesome webinar. Now, I realize that many of you are ACHE members who are attending to earn credits towards board recertification, or maybe you're an ACHE member going for that fellow status, that FACHE board certification for the first time. But some of you may have just really been interested in palliative care and just happened to see this learning event, afforded in your network or on LinkedIn or however you learned about it. So I just wanted to take a moment to talk about ACHE, just in case folks don't know. ACHE's vision is to be the preeminent professional society for leaders dedicated to advancing health. Our mission at ACHE is to advance our members in healthcare leadership excellence. Our values are integrity, lifelong learning, leadership, and diversity and inclusion. For over 85 years, the American College of Healthcare Executives has focused on one mission: advancing leaders in the field of healthcare leadership excellence. We are the professional home to more than 48,000 healthcare executives around the world who are committed to those values of integrity, lifelong learning, leadership, and DEI. And with today's rapidly changing healthcare environment, we remain more committed than ever to being the preeminent professional societies that you can count on to help you gain valuable knowledge to improve health for your patients and your communities. And in addition, through our established network of 76 chapters, Oregon's #1, you have access to networking, education, and career development at the local level. Members can also earn the prestigious gold standard FACHE credential, signaling board certification in healthcare management. So if you'd like to find out more about ACHE and becoming a member, please visit www.ache.org. If you want to get a look at the local flavor, you can go to www.oregonache.org. We're formerly known as the Oregon Society of Healthcare Executives, but we rebranded as Oregon ACHE just a few years ago. Our board members span the state in a variety of roles, a variety of disciplines, a variety of organizations, and our goal is to provide those local learning and networking opportunities here in our beautiful state. So sometimes those local opportunities are virtual, and we have people from all around the country and the world join. So it's so great to have folks here today. And you can find out more about getting involved in a committee and other opportunities to get involved with the chapter at our website. I'll drop my email in the chat in case you'd like to find out more about getting involved, Oregon ACHE, or anything else. But with that, without further ado, let's kick it off and talk about palliative care. I'm so thankful for our panelists and our talented moderator who's joining us today. I'd like to introduce the moderator, and then I'll turn it over to his capable hands. Mihir M. Kamdar, MD, is head of clinical delivery for Tuesday Health, a value-based supportive and palliative care company. He is the former section head of the Division of Palliative Care at Massachusetts General Hospital, assistant medical director of telehealth at Mass General, and the director of the Mass General Cancer Pain Clinic. Trained in internal medicine, Dr. Kamdar is dual fellowship trained in both palliative care and interventional pain medicine. His clinical and research interests center on the design of innovative, early, integrated models of supportive and palliative care, and he serves on the teaching faculty at Harvard Medical School. Please join me in welcoming Dr. Mihir M. Kamdar. Thank you, Dr. Kamdar.
Thanks, Valdez, and thank you all for having me. And I'm excited to be here with this amazing group of panelists talking about an issue that is so important to my heart, which is palliative care. You know, I think if we just take a second and you all think about maybe your own experience with family or friends as they got sicker, maybe if they're dealing with a serious or terminal illness, and thinking about those last, few months and weeks and days, for a lot of us, those times were incredibly challenging. And what we know is that in the United States, we don't do very well in terms of caring for folks at the end of life, particularly in that last year of life. And in fact, the Institute of Medicine almost 10 years ago came out with a pretty scathing report. It was a 100-page document called Dying in America, where they noted that most patients in the US, despite all our resources, suffer significantly with physical symptoms, emotional symptoms, and that last year of life. And that's a ripple effect. It's not just for the patient, but also for their loved one, right? Their caregiver. If you've ever been in that role, you know how stressful that can be. And all of that leads to really terrible outcomes for folks at the end of life. We don't utilize hospice enough. The quality outcomes for patients and their bereaved loved ones aren't very good. And there's a significant cost curve, as you all know, in that last year of life. And so that report actually said one of the biggest answers to this problem is actually palliative care. And that's actually going to be the focus of what we talk about today. And we're gonna, really make use of the wonderful communal mind here of our panelists. I got a bunch of questions that hopefully will be relevant to you all in the audience. And after we get through the questions, we'll definitely open it up for discussion. And along this journey together, feel free to put questions into the chat, and we'll make sure to get to them in the discussion section. So why don't we start out by we'll just go around and introduce our panelists popcorn style. And if our panelists can just maybe say tell us who you are, where you work, maybe about why you chose a career in palliative care. You know, it's palliative care is a subspecialty, just like cardiology or oncology, but it's one of the youngest. It really only has been formally around for just over 15 years or so, and so I think it draws a really interesting group of dedicated clinicians who all have their own story as to how they got there. So if you guys could share a little bit about that, and then maybe a bit about the palliative care structure at your own organization, since there's a lot of variability organization to organization. So, Dr. Turlin, why don't we start with you?
Sure. Thanks, Mihir. Good morning. I echo everyone's welcome. Thank you for spending part of your Friday with us to talk and learn a little bit about palliative care. My name is Kelsey Turland. I use she, her pronouns. I'm a palliative care physician and the medical director for palliative care at Samaritan Health Services here in Oregon. I've been in practice a little over 11 years and with Samaritan for the past 4. I was drawn to palliative medicine. I think I'm a little bit atypical. Even before I went to medical school, I had spent time working in nursing facilities and volunteering with No One Dies Alone, which is a program in which volunteers sit with dying patients who have no family or friends to be present with them. That really sort of piqued my interest in end-of-life care and caring for people living with serious illness. I'm a family physician by background, but I did go directly into my hospice and palliative medicine fellowship after completing my residency training. I think I had a very romantic notion of what it means to be a physician. I really desired these sort of deep relationships with my patients and the people who care for them. And while my relationships might not be long with my patients, they are very deep and meaningful. I really value having the time that I need with my patients to support their understanding of their illness, to assist with relief of their symptoms, and hopefully in turn improve their quality of life, and to support them in making value-based medical decisions. When I tell people I'm a palliative care physician, often people say, "Oh, that must be so hard." And, certainly it can be. And it's also really, really rewarding work. I'm very passionate about the work that I do. Palliative care at Samaritan is a smaller department, but with a growing footprint. We have inpatient consultation services at 3 of our 5 hospitals. So our main medical center in Corvallis, a community hospital in Albany, and then a critical access hospital in Lebanon. We also have a community-based palliative care program that sees patients in their home or wherever they call home, often in facilities, across rural Lynn County. And then I'm very excited that we'll be reopening a small clinic-based practice in rural Lincoln County next year. We are very lucky that we have robust interdisciplinary teams in our hospitals and with our community and clinic programs, and really strong relationships with the other medical providers in our communities. Certainly, while we have this growing footprint, there are parts of Samaritan's service area where we do not have palliative care coverage. So there continues to be a lot of opportunity for growth and certainly a lot of need in our community. And I'm really excited to share some of sort of how I think about palliative care and how we might fill those needs over the course of our webinar this morning. And how about if I turn it over to Jen Levi to introduce herself?
Thank you, Kelsey. Good morning, everybody. My name is Jen Levi. My pronouns are she, her, and I'm a licensed clinical social worker. I've been in practice for over 20 years, started out my career in rural Florida, actually as a hospice social worker. I moved to Portland, Oregon, and was really intimidated by the volume of social workers practicing here and didn't think I was ever going to land a job. And I was interviewing for a hospice position and they said, "Oh, we're starting this program at 2 of our big hospitals and it's a palliative care program." And I had actually never even heard that word before. There certainly wasn't any fellowships, board certification, or any kind of additional training available for social workers. And I don't even think physicians had their board certification available at that time. And so I said, yes, I love healthcare innovation. I want to be part of this. And at that time we were starting the program at our St. Vincent's Hospital in Portland, which is our second, it's the second largest hospital in Oregon. And they wanted a full-time social worker to anchor the program, which I felt was really unusual and incredible opportunity for me. And I had a part-time RN, a part-time physician, and a part-time chaplain. So we started out our program as an interprofessional team, and it grew substantially, as you can imagine. And now we have interprofessional teams across 5 of our 7 hospitals in Oregon, employing over 50 palliative care clinicians. And it's been really incredible to watch this program grow and change over time. We do have an outpatient component of our program as well. And I've felt very fortunate to be able to be part of this program for so long. And, you know, as Kelsey was talking about the rewarding work, social workers, we have a strong social justice lens in our training. And I don't know that people think about palliative care as social justice or an activism role, but that's absolutely what I feel like. I feel like an infiltrator of in the healthcare system of people that actually get to advocate for patient autonomy in a way that no other healthcare clinicians can do. And so that is how I view my role in palliative care. I'm going to hand over to Dr. Lee.
Thanks, Jen. So my name is Jeff Yee. I'm a general internist by training. And my path into palliative care was a bit, I'll call it fortuitous or flowing. When I first began, I'm working in the Sacramento area. And I started my career in a community outside of Sacramento, a smaller community of about 50,000 called Woodland. And I came into a practice there and inherited the practice of a physician, and it was mostly older patients. And it being a smaller community with one hospital, a handful of skilled nursing facilities, I must have said yes to someone somewhere, and all of a sudden, there are all these different organizations, all these support organizations say, hey, would you like to help us out? Would you like to, we could use physician input, and that rapidly became a practice of older patients and helping serve in director roles with home health agencies, assisted living units, dementia units, adult day. And those are wonderful experiences. And I got to really see the ups and downs of the care of our patients through the entire care experience in different settings. In the 1990s, then, following the lead from Oregon, the California Healthcare Foundation decided that they were going to adopt the POLST form. And my thinking was, well, I'd rather be on the in from the beginning and helping shape this rather than being told how it's going to happen. And being situated right next to Sacramento, we became deeply involved and helped push the legislation through to get it adopted, and created much of the framework and early education. And while many people see the POLST form, which stands for Physician's Order for Life-Sustaining Treatment, as a list of menu items like CPR, like ventilator care, about what a patient wants or doesn't, or may not want, I realized that it also, beneath the surface of that, helped reveal patient values about what's important to them. For instance, someone who says they want CPR, an older person who wants CPR, but also indicates that they don't want a feeding tube. Well, what's the value behind that? What's the person saying? The person is saying, you know what? I want you to try your best with medical interventions. But if I end up in a situation where I'm so impaired that I can't function on my own, that I need to have a feeding tube, that's not the type of life that I want. So we started to see that, hey, this is a great opportunity to talk about prognosis with these situations and the importance, the centrality of understanding what the patient values are. That drives those decisions. And I think that's really the heart of great medicine in all settings. So being a part of that led to more and more of palliative care-based work. I moved into our sister medical group, Mercy Medical Group, based out of Sacramento 5 years ago, and that just gave me access into a greater network. And I serve as the division head of palliative care in Mercy Medical Group. Our medical situation in California has that physicians practice in the medical groups, and the support services, though, are based in a foundation model. So we don't directly employ all those support services, and so that leads to some interesting structures. Palliative care here in Sacramento with Dignity Health, our larger organization, it does have inpatient and outpatient components. And as many of you are here, if you've seen one palliative care program, you've seen one palliative care program. That is true across all the different sites that we work in. We have 5 hospitals. The structure and support in each is different. Ranges from having a nurse practitioner as a solo practitioner to a full interdisciplinary team with physicians, social workers, and RNs. So it's just different in each hospital. It's driven by that hospital culture and support. When I came to a Mercy Medical Group, the outpatient palliative care for the organization was 1 clinic day a week by 1 clinician working in an independent fashion. Since that time, we've grown to having clinic 5 days a week, and we've opened up a home-based visit component. And we actually really feel that the home-based component is what's driven or allowed for the growth of our ambulatory services. As a standalone physician group, though, we provide the medical services. The foundation provides the support of through an arm called care coordination, and therein lies a collaboration with social work and RNs. And though it is something that we continue to work on and we build locally, that continues to be a work in progress. So I'm really, really excited to be sharing the work that we do and how we do it, and the understanding that palliative care is an important, essential part of care, but it's going to look different in each and every setting. Thank you.
Thanks, Jeff. And I couldn't agree with you more. Just about when you've seen one palliative care program, you've seen one palliative care program. And I think that speaks to oftentimes the organic nature, as you were saying, as palliative care grows based on need. And I think what can also facilitate that, though, is leadership's the insights into the difference between not having palliative care and what palliative care can mean in terms of population health outcomes, cost elements as well, in addition to obviously be doing the right thing for the patient and their family. And so I'll just quickly share a little bit about my path to palliative care. I had not heard of palliative care at all 20 years ago when I was an intern. And my first month was on an oncology rotation. I had 2 patients die before lunch on my first day. And I thought, this is going to be a really long 3 years. And it was one of the few places at that time that actually had palliative care consultants. And when you're an intern, you're not getting called for major treatment decisions, which chemotherapy should we use. You're getting called for pain and nausea, and it's 3 in the morning, and this patient is crashing, and no one's talked to them about their metastatic pancreatic cancer and whether or not going to the ICU would make sense. And I remember you'd call palliative care and they would come in and they would just make everything better. They would help with the symptoms, they would help the family, they would clarify goals of care, and just the ease and the relax that you could see in these patients and families as they were going through a really hard time was just powerful. And the other thing I loved is they sort of stay in the room when, other clinicians might say, we have nothing left to offer because there's always more we can offer, and would really kind of see things through for that patient and family, which was just powerful. It was so human. And so I fell in love with palliative care, decided to do it as a career, took on different leadership roles, and for the last several years served as the section head for palliative care at Mass General. We grew from, I think, 14 clinicians when I started to about 75. And we expanded from just inpatient and a very, very small outpatient presence to a large inpatient team. I think the third largest consult service at Mass General, a very large outpatient program. And then we built home-based as well as embedded emergency department and a palliative care unit in the last couple of years before I left. And I loved academic medicine, and it was amazing. And it was wonderful to lead and do research. I think the challenge I was seeing is, as we'll discuss, is the needs are significant right now in the US, particularly in the community. And the research we were doing was great, but the 5 to 10 years it was taking for the outcomes to actually reach someone at the bedside just weren't sitting well with me. So I helped come together and start a palliative care startup company called Tuesday Health about a year and a half ago. And it's really all about, Jeff, to your point, delivering care in the home, whether that's in someone's home or in an institution where they reside. Because there's huge gaps in access in the outpatient and community side. I saw one of the questions in the chat that we'll get to related to that because there's significant need. So Jeff, it's interesting to hear about your experience with what your home-based program is driving. And we operate, one of the things we'll talk about is sometimes the financial challenges of sustaining a palliative care program in a fee-for-service world. So we're in a value-based care model working with payers and at-risk providers because the fee-for-service element can be a barrier to really creating widespread access and scale to palliative care. So, but I think let's come back to the basics. And so Kelsey, I'll start with you. This is a two-part question. First, how do you define palliative care? Like everybody knows what cardiology is or orthopedics, but how do you define palliative care? And with that first part of the question, what are some of the misconceptions you commonly see related to palliative care?
So palliative care, I think of, and kind of definitions you may see online are, it's specialized care for people who are living with serious illness. I think sometimes that phrase of serious illness can feel like a little bit of a nebulous term, but really we see patients who are living with cancer, advanced heart disease, advanced lung disease, advanced kidney disease, advanced neurologic diseases like dementia, Parkinson's, ALS, among a variety of other diagnoses. As we've talked a little bit about when we've talked about sort of our passions for palliative care and our different models, it's really focused on providing relief from symptoms and stresses of illness. This is the symptoms and stresses that affect the patient themselves, but also the people who are important in their lives, their families and their caregivers. The goal is to hopefully improve quality of life, both for the patient and for their family. When I introduce myself in the room to a new family or patient, I talk about how, myself and my team, we provide an extra layer of support to help make sure that patients are well informed about their diagnosis and prognosis, that their symptoms are managed, and that the medical team is really hearing their voice about what their values, priorities, and preferences are, so that we can make sure we're providing them with the best care possible that's in alignment with their goals. I loved what Jen said earlier about sort of this social justice bend on palliative care and this kind of advocacy role that we take. I completely agree with you, Jen. I think often when we get involved, patients' voices are heard in the healthcare system, maybe in a way that they haven't been heard before. and we really are able to help make sure that patients are receiving goal concordant care, which is hugely important. We'll talk a little bit about this probably later in our webinar, but when I think also of sort of the definition of palliative care, it really requires an interdisciplinary team who are trained in advanced communication techniques and complex symptom management. And I think it's really important that we acknowledge that it takes time to provide high quality palliative care. So having specialists who have protected time to be that added layer of support is really important. That support, initially for the patient and family, but it really does extend to our colleagues, across the hospital or primary care outside of the hospital. When we can take that time to devote to these intensive family meetings, to patient and family counseling, helping answer questions and resolve conflicts, it really does free up time for our colleagues to be able to do what they do best. And I think these longer encounters, when they're protected, really help patients and families to feel heard and improve satisfaction. You asked about misperceptions, and I think there's several. Probably the most common ones are that access to palliative care would be dependent on a specific prognosis. I think often palliative care and hospice are thought of as synonymous, but really they are kind of a spectrum. Palliative care can come alongside at any stage of serious illness, including while patients are pursuing life-prolonging or sometimes even curative treatments, whereas hospice is really meant for patients who are in the final 6 months of life and prioritize comfort as the focus of their medical care. We work very close together, and let's talk about, you've seen one palliative care program, you've seen one at my organization. Palliative care and hospice are separate departments, but sometimes they are together in a single department or from a single organization offering both services. Another common misperception that I think I hear is this fear from maybe even my colleagues in medicine that introducing the palliative care team is going to take away hope. And we know that patients want open and truthful conversation with their clinicians. Mihir was talking about the experience of, as an intern on a busy service and having the palliative care team come in and just like de-escalate the stress in the room. People want to talk about these things. It's not universally true, but people do want to talk about their prognosis. They want to plan for the future. And they need somebody who's able to sort of crack open that door and start that conversation. And that's something that palliative care can offer in a really kind of gentle and patient-centered way. And I think it's important to also recognize that hopes shift through the illness trajectory. So maybe while early in serious illness, patients are hoping for as much time as possible, as illness progresses, hopes may become refocused on things like feeling valued or having meaningful relationships, on humor, on comfort. And so I really think it's important that we sort of reframe that and think about how hopes change, but hope isn't lost. So involving palliative care and that extra layer of support really is hugely beneficial for patients, for helping them cope with those changing hopes. I'm going to pause and see if anyone else wants to chime in on this.
Kelsey, I thought that was great, and you said a bunch of, I think, really important stuff. Like, there is this misconception of hospice and palliative care, and again, like you said, I'll just reiterate: palliative care can be provided at any stage alongside curative treatment. I think really anybody who has a serious illness that's going to have a rocky course, whether it's physical symptoms, emotional symptoms, really could benefit from palliative care. We'll talk about the resource access challenges and the workforce shortage, which presents a challenge, but I think that's really key. I also really loved your commentary on talking about the possibility of dying. Actually, it doesn't take away hope. That's a common misconception that physicians have and other clinicians, and yet there's a bunch of studies, to your point, that show people actually have less anxiety and depression. And you know, when a patient does pass away, their loved ones with just a single conversation have less anxiety and less risk of pathologic grief. So it's a real kind of paradox. And we know that, to your point, like 70 to 80% of people, when they pass away, want to be at home and they actually want to know and they want to plan. And yet in the US, it's the opposite. 70, 80% of people actually don't die at home. And there's a lot of reasons for that, but part of it starts with us not really having these conversations. What can you talk a little bit about, like, why do we need the field of palliative care? Like, shouldn't every primary care or every, you know, oncologist or heart failure doc be able to do this stuff? It's talking with patients, it's managing symptoms. Shouldn't that be core? Like, why do we need a specialty?
Yeah, I think my colleagues in general outside of palliative care are pretty good at starting these conversations, at having that initial goals of care conversation, at providing medical information. But I think often my colleagues are pressed for time. It's hard to talk about all of these things in a 20-minute office visit. And so I think if my non-palliative care colleagues are able to kind of crack that door open and start the conversation, acknowledge that it's going to take time, and then connect them with the team that has those advanced communication trainings, those, the training on advanced symptom management, and then connect them. I really think sort of that's where we show value for our patients, but also in support of our colleagues. I think having that protected, dedicated time and the training in advanced communication and symptom management is really critical. And yes, a lot of doctors are doing primary palliative care, but the need for specialty is real.
Yeah, I agree. We're going to talk more about primary versus specialty palliative care, but as you said, most of us, maybe I'm dating myself, weren't trained. I trained in internal medicine. This is something we see dying all the time. And I wasn't trained in how to have these conversations. I wasn't trained really in much more than basic symptom management. And it's also, I think, hard for, let's say, a busy primary care clinician who's got 15 minutes and, churning through the day to, even though they want to, I find they oftentimes want to do this and have these conversations, but they need help. Particularly also if it's complicated, if there's, complicated family dynamics or complicated symptoms. So yeah, thank you. Jeff, I'm going to turn to you and ask, like, what are the benefits of palliative care in terms of, patients, caregivers, and then as we think about that end of life journey, the outcomes there, including cost. Like, we never like to think about cost. It feels a little icky to think about cost when we're talking about, people navigating serious illness, but it's a reality as we think about, about the healthcare system. I guess another way to say this is why should folks in the audience, why should healthcare executives care about palliative care?
Oh, it's a great question, Mayar. And I think there's really strong arguments, and the first really strong argument actually comes from your institution, though. Looking at you and your youth, I'm not sure if you were there at the time for that Sentinel study from 2010. So I'm referring to a study that was done at Mass General where they randomized patients with lung cancer to palliative care or routine care. And lo and behold, there was this tremendous impact of palliative care, where there was actually an extension of life. And that extension of life was on the order of about 30%. So average survival went from just about 9 months to 12 months. And that was something. So here's something where that's a meaningful statistic to patients, and and numbers are something that, as we talk to healthcare executives, they need to be able to see things in quantifiable fashion. And if you think about a drug, if I were to take a drug to market that extended life by 30%, just think about how powerful that is, and what people would be saying about the economic impact and the value of that drug. So so that's just a clear statistic that helps us show in one aspect the value of palliative care. When you look at that study further, though, the patients felt better. There was less depressive symptomology. There was less futile, I'm going to call them, from my perspective, futile interventions at the end of life. And so that leads to the second reason why we need to why we all should be paying attention to the impact and the presence of supportive and palliative care. And that is the patient experience. And that really summarizes all the wonderful things that can happen in these situations, many times in which, as was pointed out, the patient being told, well, there's nothing else we can do. And we find there is always something to do. And that's my prime directive to our palliative care team when they go out, is that always when you leave that patient, let them know what the things are that we are going to be doing for that patient. And so we find that levels of anxiety are greatly reduced. We find that symptoms are better managed. And that makes sense, that when you have a clinician, when you have a team focusing on those aspects of suffering and the concept of total pain, then you see improvement. We know in other disease states, when you have a diabetic team that focuses on diabetes, you see improvement throughout your patient population in the management of the diabetes. When we bring the resources to bear to focus on the suffering of the patient, and that is what we do in supportive and palliative care, is focus on the suffering of the patient, we see improvement. And Kelsey, I think it's important that, as you highlighted, that it's not just about the end of life. So I've seen programs where they have exhaustive lists, similar to, almost aligned to Medicare hospice criteria, where there's these entry criteria and for palliative care services. We've taken a much simpler approach and say, okay, a serious illness plus stress, tension. And when a clinician recognizes that there's that inordinate stress or tension, that's where additional support will likely be helpful. We find that stress and tension idea, that can be something that you see within the patient. That can be something that you see within the family and family dynamics. You could see that stress and tension within your own care team and how they're having difficulty dealing with the patient and family. Or you see it within the system, and as manifested by high hospital ER utilization. So those are ways in which we start to see the value of supportive and palliative care.
Yeah, thank you.
We, in our own experience, were able to generate. So again, we see that, and again, I think, as I've found through time, that in order to develop my collaboration, in order to get attention from those from the healthcare system for the support that I need, data becomes important. So we were able to, within our group, start to gather data in terms of cost of care outcomes, primarily on hospital utilization. So we're able to take data for hospital utilization for the 6 months prior to the first palliative care encounter, and then for the 6 months following that first palliative care encounter. And we see 30 to 50% reduction in the number of hospital admissions and ER. The
Jeff,
other
that's,
important,
I was just going to jump in. That's really impressive, and I think speaks to a whole lot of things. You talked about the multiple benefits of palliative care, not just for the patient, the caregiver, but I love that you spoke also about the other clinicians in the team, because oftentimes there's a lot of moral distress around these patients. And I actually think about our colleagues, particularly in the era of high clinician burnout. I think this is a leading driver when they're seeing these kinds of challenges and feel like they can't enact the kind of care that they want, is really key. And I think, as you're just speaking, like that kind of cost savings is significant, right? And I think not a lot of people realize how much of a cost savings there can be with palliative care, right? And it's this rare element in medicine where the Venn diagram of doing the right thing for the patient and outcomes and cost reduction actually align. Which is really, I think, critical as we think about the benefits of palliative care. And, you mentioned the cost savings. I think, also beyond that, there's as we think about for the audience, like there's the hospitalization and readmission avoidance, right? There's the reduction in lengths of stay. There's all of these other potential benefits as we think about on a systems level, right? That I think are relevant, really important, for the audience. So I think to that point, one of the challenges, as we were talking about, is this all sounds wonderful, but the challenge with palliative care is like, how do you sustain it financially, right? In terms of being able to bill to cover a clinician's salary. When I was at Mass General, I always kind of made a joke. I wish we did endoscopies or hip replacements because we could grow more quickly. But so I think to that point, Jen, would you be able to talk a little bit about like how we think about financial sustainability, the cost savings versus of quality care? Like, how do you, maybe another way to say this, like, how do you make an argument at your institution for, either palliative care in the first place, if places don't have palliative care, or expansion of existing palliative care, knowing it's a cost savings model, it's not a revenue driving solution. And maybe also a little bit about how do you think about making an argument for an interdisciplinary team as well?
Yeah, thank you. So I think about this in a way of like I would say physician wellness. And when I think about kind of the overall view of what's happening in healthcare across the United States, I think the word that comes up for me is grief. And when you are looking at interprofessional teams that exist with palliative care, social workers and chaplains, we have training around grief. We understand family systems. We understand how to attend to high emotions. And when we have an opportunity to partner with hospitalists, with primary care clinicians, and we have built a relationship with them over time, their wellness and their work, the fact that many physicians feel like they've lost meaning and purpose of why they went into medicine, we have this opportunity to walk alongside them and remind them why we're doing this work. And when you think about cost savings, physician retention is a huge cost savings. And I think that we have a strong case for that. And so that is one way that I think about cost savings and wellness. But we also do things like partner with the money makers in the system. So the cardiology teams that are doing TAVRs, LVADs, heart transplants, if we have a strong relationship with them and they see that they need us, if we align ourselves with the folks that make the majority of the money at the hospital, and they don't feel like they can function without us, which is what we have done in our institution, then we're going to have some longevity. And so we do have to be creative and shift over, like, the culture and of medicine changes, for all of us that have been in healthcare for, decades. It shifts and changes. So we have to be adaptable to that as well. And I think that when we talk about interprofessional work, in our system, our social workers have advanced training in initial assessments and facilitation of family meetings. And, when you look at length of stay in hospitals and what's happening to care management departments and the payers, and this kind of fast-paced thing that's happening for folks, we actually can help reduce readmissions and help come up with a really good plan for folks for when they leave the hospital, that other clinicians are not having the time to do these deep assessments that we do. And I know it always goes back to time, but we also, because of our advanced training in assessment and communication, we actually are also efficient in building rapport and relationship really quickly, being able to bring the concept of death into the room, into the conversation early on, and giving folks the opportunity to plan for their future when time might be really short and nobody else is really kind of talking them through that. So I guess, in a nutshell, I would just say the way that I think about the cost savings is this interprofessional concept of attending to moral distress, of bringing meaning and purpose back into healthcare and aligning with our colleagues.
I love all that, Jen. It was interesting. It took about 10 years, but the culture change we saw at Mass General, for example, in oncology, when we would expand to a new satellite in the community, our oncologists didn't want to go out there unless they had palliative care going out there with them, which was really, like, remarkable and warmed our hearts to hear. But I think it speaks to what you were talking about. And when we think about the cost of replacing a clinician who's left is, near 7 figures. It's not a small thing. And I also love the piece you were talking about having the time to really come up with comprehensive plans of care to avoid readmissions. We also know that palliative care can shorten length of stay, as I was mentioning. And for me, when I was in my role at Mass General, it was really trying to sit down and understand what are the pain points for the organization. Is it length of stay? Is it readmissions? Where are we at with 30-day mortality, right? And are there ways, a lot of the folks that are coming in, probably were hospice eligible, just no one was having these conversations. Another example of a quality indicator would be chemotherapy in the last 30 days of life, right? So again, I think whenever we can identify where the pain points are at in the organization and then be able to help folks see the data behind what palliative care can do in both quantitative and qualitative, means, it can be really powerful and helpful for growth. Because the challenge we had at Mass General was anytime we wanted to add a clinician, we'd have to subsidize, it has to ask for salary subsidization. So we really had to make the argument, both that it was the right thing, but also from a cost lens. So thank you for that. I'm going to circle back to you, Kelsey, about how we think about timing of palliative care. And Jeff, I was pointing to the gray in my hair earlier because I appreciate your kind compliment, but I was a fellow during that study, so I got to see those patients during that pivotal 2010 study. But Kelsey, when should palliative care get involved in the care of patients? Because a lot of the data suggests most palliative care, even though despite its growth, gets involved on the inpatient side, usually in the last admission or two before someone passes away, maybe a couple of weeks before they pass away when they really should have probably been on hospice. So when should palliative care get involved? And what are some strategies that organizations can deploy or that you've seen to help identify those patients? I think there was even a question in the chat about this.
Yeah. So I think my answer is the right time to involve palliative care is early in the course of serious illness. The study that Jeff was talking about, these patients were referred to palliative care, at or near the time of diagnosis with lung cancer. And being involved early with palliative care, having a team focused on managing symptoms of illness, managing the side effects of treatment, identifying changes in illness sooner. These are the ways that we keep people out of the hospital. If we can intervene early, get symptoms under control, people don't go to urgent care. They don't go to the emergency department. If we can have these conversations about changing illness in the home or in the clinic, as illness is starting to change, we can help people navigate that transition to hospice without a crisis admission to the hospital. I think absolutely there is value of palliative care on the inpatient side in terms of, length of stay and sort of planning for discharge and how we're going to support someone when they leave the hospital. But I think more and more we see the value of palliative care upstream of the hospital, early and serious illness in the clinic, in the home. On the inpatient side, we do see data that shows that involvement of the palliative care consult service in the first 72 hours of a hospitalization. So again, early palliative care, early in the admission, is where we see improvements in patient satisfaction and decreased length of stay. So clearly benefits in both realms, but really the earlier, the better. If we can build this rapport and have these conversations as illness is changing, we can help people navigate and get that goal concordant care at the right time in the right place. How we identify patients early, though, I think there's several different strategies for this. Some organizations have used sort of triggers based on diagnosis. So I've worked at organizations where patients automatically get a palliative care referral when they're diagnosed with metastatic lung cancer or pancreatic cancer or glioblastoma. There are triggers for some organizations for a patient who is admitted to the intensive care unit from a nursing facility, or a geriatric trauma patient who's admitted to the ICU. So these things are sort of automated. We know these patients have a higher likelihood of having, a poorer outcome, either morbidity or mortality. And so identifying them on admission, identifying them early in the course of their illness, just simply through a diagnosis trigger, can be one way of doing this. Some organizations are also able to kind of pull data looking at patients who have a serious illness, who are frequently in the emergency department or in and out of the hospital a lot, and kind of flag these patients to their primary care doctor to consider a referral to palliative care. There are like HEDIS data sets for advanced illness that sometimes organizations use to say, okay, this would be someone with serious illness. Now, which of these patients are in and out of the hospital a lot? Which of these patients are our high utilizers? At Samaritan, we've partnered with our ACO REACH partner, and we've collaborated to create a method of identifying patients with serious illness who would benefit from specialty palliative care. At certain intervals, I get lists of patients from our ACO REACH partner, and then engage with PCPs to encourage a referral to palliative care. I think there's a lot of sort of creative ways based on diagnosis, based on utilization, that we can identify these patients. And a lot of it is also what you guys have been talking about. It's about building relationships with our colleagues. It's about demonstrating our value. It's about, having the oncologist or the cardiologist say, no, I want palliative care in my clinic. Because the more we can build relationships, the more likely people are to think of us and send patients our way.
Yeah, terrific answer. And I think if I think about all the different ways that you talked about to identify patients, I think one of the take-home points is it is hard. It's not going to work well if we just rely on clinicians to identify patients. Folks get so busy. We know there's lots of data that we're not very good at prognosticating because we're human. In fact, the longer we know a patient, the worse we are in prognosticating. And so I think that's why you've seen a lot of organizations really try to use different triggers or structured means of identification to identify folks earlier. A lot of the research on early integrated models suggests that 12 to 18 months before someone passes away is really the sweet spot. That's what we use at Tuesday Health. We use claims-based identification measures, looking at both risk and mortality and morbidity to try to get to know folks because, the point you were saying, Jeff, like, it takes time to get to develop these relationships with the patient, their loved ones, and their providers, as you were saying, Kelsey. And a lot of the research suggests it takes 4 to 5 conversations to lead to a change in goals of care. That's goal concordant, which is another term you use that I wanted to just to say for the group. That what that means is really understanding, a lot of the work is understanding what's important to a patient. If time is short, how do they want to spend that time? And then making sure the medical care is concordant with that. And that's what we mean by goal concordant care. And that's, really, is Jen was talking about social justice. That's really an ethical construct that we need to make sure is in line with what happens to our patients. But without palliative care, unfortunately, it doesn't always. I'll ask one more question, and then I think we'd love to open it up. There's a bunch of questions in the chat. We'll open it up for discussion. But Jeff, can you just speak in a couple minutes about like the challenges we have related to the workforce shortage in palliative care? Because one of the challenges, we do all these triggers, but do we have enough clinicians to meet those needs? And so like, how do we think about the workforce shortage? Can you speak to that? And then can you talk a little bit about specialty versus primary palliative care? Kelsey mentioned that earlier. Could you just define those for the group?
Sure. So I think first the nomenclature of primary versus specialty palliative care. And I think we would be saying that primary palliative care is any palliative care interventions, interactions that are not performed by a specialty focused palliative care team. And so that drives the idea of primary palliative care interventions back to frontline clinicians, whether they're primary care, whether they're surgeons, whether they're cardiologists. And that picture of workforce shortages can drive the dynamics quite a bit. Estimates are in the thousands of shortages in order to meet projected palliative care needs. I'm going to actually make a pitch that we think about our primary care palliative care primary care interventions not necessarily restricted to a person, and that the system patients benefits when we have the capacity to provide those interventions, again, Kelsey, as you've said, further upstream at the sites of their care. The average palliative care referral is seeing, I believe, 6 or 7 consultants already. So we have to so the more that we can deliver earlier upstream, then the more continuity in their experience and less fragmentation. So it's a pitch on both sides, because what the specialist has that the high volume primary care centers don't have is time. And many of these palliative care interventions, beginning conversations, can be enhanced through teamwork at the primary care physician side of things. So I want that just to open up thoughts about that. Yes, we have specialized training in communication and being able to facilitate conversations with patients and families about things that they don't want to talk about is a special skill. And there's good evidence that that's more effective. Yet on the other side, and so we have that training, and we also have that important element of time. And I think those are some of the distinguishing factors in between specialty versus primary palliative care. In particular, in regards to communication and trying to develop goal concordant care plans.
Yeah, thanks, Jeff. And part of this push for primary palliative care, again, just for the audience, the idea that how do we educate non-palliative care clinicians on core symptom management, communication skills that every clinician should be able to utilize? Because as I mentioned, I didn't get trained in a lot of this stuff. Is really key, because like I think some data came out last week that there currently in the US, there's one palliative care clinician for every 100,000 patients, right? So the math doesn't add up. We estimate by 2050, around 80 to 90 million people will have some sort of palliative care need. And so what a lot of, as the field is trying to figure out is, okay, how do we think about pointing the spear of specialty palliative care in the right direction for those patients that need it most, but try to upskill non-palliative care clinicians to be able to meet the rest of the needs because the math doesn't add up. So that's where you'll see folks do, system-wide communication trainings on serious illness conversations, things like that. To your point, Jeff, it's really not an individual element. It's a systems element that needs to be addressed. And we still don't know whether some of those we don't have data really in full whether the primary palliative care interventions are ultimately going to be the solution. But I think they're worth us trying in the interim. I'm going to bring in some questions from the chat, and if folks in the audience have questions, feel free to ask. But Maurice Stout asks, I'm remembering the Choosing Wisely campaign a decade ago. Are there communication campaigns or toolkits that can continue the advocacy and evidence supporting palliative care? So anybody want to take that one? It's a great question. Jen, I see. Or go ahead, Kelsey. Yeah.
So when I was in my fellowship, we did a lot of work with Vital Talk, which is another organization that does advanced communication training. They have beautiful talking maps for how to sort of navigate serious illness conversation, navigate a family meeting, but they also have some talking maps for how to sort of talk about palliative care to administration as well. And then I know that up at OHSU, they have a group who has a grant. They're calling their program Talk Oregon, that they're partnering with healthcare organizations across the state. Samaritan is one of them, to send folks from the organizations to Vital Talk Train the Trainer training, so that you can come back to your organization and then offer these advanced communication trainings to folks at the organization. And so we're in the early stages of that here at Samaritan, and have good partnership with some of our graduate medical education programs, for myself and our hospice medical director to do these Vital Talk trainings with our residents. And I'm really excited about that, about being able to impart some of these skills early on to our early career doctors.
And Jen, are there any things you think about resources for from the community standpoint for helping folks kind of think about patients or caregivers, like thinking about these conversations, or toolkits that you think about?
Yeah. So I want to just kind of add on to what Kelsey started to say, that, yeah, we in our health system, we've implemented Vital Talk trainings throughout our healthcare system, residents, primary care clinics, kind of to really shift the culture. And part of what we are doing in terms of our primary palliative care training does hopefully leak out into the community, because we are doing whole clinic trainings on palliative care. So the front office folks, everybody that works in that clinic will have basic understanding and training around palliative care. We're also doing trainings with interpreters in the community. So we're accessing folks with limited English proficiency. And so our goal is to normalize palliative care into the community in ways that we have access, just culturally, and just linguistically, to help people have a little bit more curiosity about what that means for them in either the kind of their spiritual beliefs or their cultural beliefs. And so having engagement with these communities of folks, our hope and our goal is that they take it home to their communities, working with community health workers, and that over time, it's a longitudinal plan, but we're hoping that these are ways that we are reaching the community.
That's terrific. Jeff, a question for you. Is palliative care included in most people's insurance coverage? Do they have to pay out of pocket, or does it need special authorization?
So again, because palliative care is actually a essential component of patient-centered care, I think actually for a billing clinician, we'll always be able to find reimbursement for that. I think the challenge is with the support for the greater palliative care team being able to find the resources and the flow of dollars to support the social worker and the associated nursing staff. So I think that's where the challenge is. In particular, I think I want to highlight that Medicare has an advanced care planning benefit that everyone is eligible for. And that again becomes an area in which we can start to have some of our affiliated workers, nurses and social workers help provide that. And there is the opportunity to submit those charges to Medicare when those are provided by an affiliated worker. So there are opportunities, and sometimes we have to get a little bit creative and knowledgeable, I think is the thing, is how to provide these services in a financially viable way. But yes, coverage is there.
Yeah, thanks.
Really
Yeah,
quickly.
please.
Yeah, so similar to Jeff's experience, our clinicians are able to bill for their services, and we haven't had issues with insurance reimbursing us for that. But like Jeff said, paying for the nurse visits and the social work visits, often those are non-billable visits. What we have done is create alternative payment model agreements with some of our payers so that we get a per member per month rate for our patients that we're seeing. And that helps to cover the cost of the interdisciplinary team. Negotiating those contracts takes a little while, but it is very much worthwhile for being able to cover and support your interdisciplinary team.
I think that really speaks to the, as we see more shifts towards more value-based care models, hopefully that allows greater growth and access. Because again, we need more of it for sure. It's a great point, Kelsey. Maria asked about, she's interested in outpatient and home-based palliative care models. And and then also a question about rural communities. I would say, it's interesting because, 90% of plus hospitals with 100 beds have inpatient palliative care. We still have a real lack of access to outpatient palliative care. Most outpatient palliative care, a lot of it is it's cancer focused. You might see some heart failure, but you don't really see outpatient palliative care in most places robust enough to really meet the needs. And then on top of that, home-based palliative care, which we know significantly improves outcomes for patients, but and also is associated with a 20 to 30% total cost of care reduction. Most people don't have access to it. And what I'd say is palliative care started on the inpatient side. It really needs to grow on the outpatient side and upstream, like Kelsey said, because if people are meeting palliative care who have a serious or terminal illness for the first time on the inpatient side, we've probably missed an opportunity, right? The goal is to actually keep folks out of the hospital. And so again, I'm hoping as we think about different alternative payment models that we'll see more growth in the outpatient side. But this question of providing palliative care in rural communities is a really good one. Have you all seen any strategies for that have worked well? Something, a challenge you face?
So I can share just a little bit about our community-based program in Lynn County, which is a rural county here in Oregon. We started as a pilot program focused just on patients with symptomatic congestive heart failure. We were able to pull data to show that, the patients with heart failure who were high utilizers of healthcare resources primarily lived in Lynn County. And so that's where we were able to get support to launch our program. That was so successful that we were able to expand to any patient with any serious illness diagnosis who lived in Lynn County. So we've had really good support from our system for that once we kind of demonstrated our value. The challenge, though, is that the geography of Lynn County, it's a big county. And so we're not able to be super efficient because there is so much windshield time. People are driving such long distances. And so we've had to get a little bit creative especially with our nurse practitioner, who for some of our patients is the only one who is able to bill for her services, doing more telehealth and having, a few clinic days where she's able to be more efficient and see more patients, but having our nurses, social worker, chaplain be out in the community. Once we sort of demonstrated our value through heart failure, people really bought in. and we've had good support, and I think we've been pretty successful.
That's terrific. I
Kelsey,
think
I'm
we're,
just going to
oh yeah,
echo
please,
what
Jeff.
you've said and done.
Oh,
I
go
was
ahead,
just
Jeff.
going to say, because we're fearful of the lack of telehealth. We do, and that if that happens, we've found that we like to make a face-to-face visit, but much of this is progressive communication, and much of that we could intertwine with telehealth visits and be much more efficient as one of the bright spots post-COVID-19. So.
Yeah, it's a really great point. And that's the comment I was going to echo too. I think telemedicine is key. There's a lot of barriers, health literacy, tech literacy, access to internet and hardware. But there are folks that are deploying, at no cost tablets and, that have hotspot, or Wi-Fi implication to try to help. And I think COVID, to your point, Jeff, showed us that a lot more people can use telemedicine than people had thought. So I think that's really critical. I think the other thing that can be helpful too is continuous monitoring programs. So we use symptom continuous monitoring for folks to try to catch issues between patient visits, which can be helpful. So we have about I think about 10 more minutes, and so I think I'll just ask everyone on the panel one two-part question, which is, and I'm going to build this off another great question from Marie, which is, what messaging can healthcare leaders do to amplify support for acceptance and growth of palliative care? Part one. And part two is, despite all these challenges that we talked about, what gets you excited about the work that you do? So it's a two-part question, maybe 3 minutes apiece, and that'll keep us within time. As you guys can see, we're palliative care clinicians, so we can use silence like the best of them. Who wants to go first? Kelsey, would you mind jumping in?
Sure, I can go first. So messaging for palliative care, I think the pitch to administration is, it has to be twofold. We have to talk about the financial implications of it, the cost savings, those benefits to help make our pitch. But I really want to make sure that we're also focused on the quality of care that palliative care provides. I think we have to put sort of the heart and the dollars together when we talk about palliative care. That's something, at least, that's really important to me when I'm talking with my leadership at my organization. I have to speak kind of their language of dollars, but I also have to speak the language of the quality of care and the benefits that we bring to patients and families and our colleagues and the system in general. What I'm sort of excited about for palliative care in the future, I think we've talked a lot about just the value of palliative care upstream. And that's where I see growth in my organization, is needing to build our outpatient palliative care service line. We're a 3-county service area. I have outpatient services in 2 of those 3 counties. So there's some big black holes that I would love to be able to fill. And so that's where a lot of my advocacy is right now. Also very excited about some of the primary palliative care training that we're doing. I think the more that we can make people aware of our specialty and the benefits that we offer, when people hear our story, most people are like, oh, yes, of course, this is something we want. And we just have to be able to share our story over and over again.
Yeah. Thank you. Jen?
Yeah, I would say, palliative care, when we talk about healthcare administration, I always think about the quadruple aim, and our palliative care meets all those perspectives of whole person care, cost savings. And when we think about the interprofessional aspect of it, I would just add that the ethics component of the work we do, the cultural formulation, the trauma-informed care, these are all components that people have access to when they have access to a true interprofessional palliative care team. And we can't lose sight of that. I think a lot of times programs try to say, they try to put one clinician in and then they overwork them. They don't have a team, and then they lose the palliative care program altogether. And so putting together a palliative care team is essential. I am one social worker that has stayed with the same program for 18 years, and it kind of blows my mind that I've been able to stay in the same role. But the truth is, it's because this work brings so much meaning and purpose to who I am as a human, and that I get to walk alongside folks in maybe the worst day of their life, and to be able to have a moment with them of healing, create opportunities for peace. Also provide an opportunity for folks to kind of reclaim some control in a situation where they feel that they don't have control. And to me, that is kind of the point for me of being a social worker. So I'm excited about sharing this with others in primary palliative care. That's kind of where my passion lies as well, in trying to have teach and show other clinicians that they too can have a part of this work in their practice.
Yeah, beautifully said. Jeff?
So when I talk with healthcare executives, I really, my messaging becomes twofold. One is palliative care, PC equals palliative care equals primary care equals patient-centered care. And this is the type of care that not only would I want, but that's the type of care that energizes me when I deliver that type of care. And I think, part of that messaging is that helping the systems give this type of care is the best patient experience and is the way towards sustaining our workforce that experiences high levels of burn. So I think that's my messaging that I like to give to, when I couple that with our financial data, that's my twofold message. My challenge in the future and what I'd like to do in my remaining work life is to be able to develop those skills and disseminate those skills further upstream into primary care settings, because I think for all those reasons that I just said, is because it's the right thing for the patients. And I think is what's going to help make our clinicians enjoy their work, is being able to do the right thing, know that they're doing the right thing for their patients.
That's awesome. I'll say for me, I think in terms of how leaders can amplify, I think it gets back to the piece of really understanding the pain points in an organization that matter to leadership, and being able to then overlay where palliative care can really hit on those. And Kelsey, to your point, like the nice thing about palliative care, we think about certainly value-based care, we improve quality and we reduce costs. It's a rare thing in medicine. And so I think being able to make that argument, and then Jen, as you said, what you don't want to do is just then that lead to hiring one clinician who's now has to carry the weight of all of the palliative care needs in an organization, because that's just a recipe for burnout. But I think what you need, and I also, having said that, also know that it may be hard to ask for more than that. But so within that, I think part of it then is once there's a commitment to palliative care, is making sure that there's the ability to capture data and metrics to know the current needs, and that there's a plan in place for growth based on certain metrics, so that, again, that clinician doesn't burn out, because the burnout rate in palliative care is incredibly high. I think the thing that gets me excited, I think on the large scale, if I zoom out, is being able to try to create clinical models to, as we're seeing more care shift into the home, how do we bring palliative care into the home and really keep folks there? And how do we use technology to identify folks, better predict deterioration, make sure we're getting, right sizing resource to need quickly and even ahead of that need? It gets me really excited as we think about, future innovation in our space. And the idea of using technology not as a barrier between us as humans, as some people worry, but how do we use technology to bring this limited workforce, this limited resource of palliative care in at the right times, I think is really exciting. And at the end of the day, I think, as everyone was saying earlier, the work itself is just so meaningful. We walk into these difficult situations, and if we can, the patients are so inspiring, and if we can just make things a little bit better, we've often run a fair bit of distance with them. So, and it's an honor to be able to be invited into their lives at a really kind of vulnerable time for them and their families. So yes. I think with that, we're at 25 minutes after. Yes, I just want to also echo what Jen put in the chat. The CAPC, the Center for Advancing Palliative Care, has great resources. They also have a website called Get Palliative Care that also can be really helpful as you think about local resources. There was also a recent scorecard state by state that was just released, I think, earlier this week on palliative care ratings by state, which may be interesting for the audience to take a peek at as well.
All right. Well, give it up for our awesome moderator and panelists. If you like the discussion here today, please show them some love physically, virtually, and definitely in that evaluation link that I dropped. Before we adjourn, though, and go back to Tia, our host, our program chair, Jennifer Will, is going to say just a few words about some coming attractions.
Yeah, thank you. Thank you, Valdez. And what a wonderful discussion. Thank you so much. Again, Valdez put in the survey. Please fill that out. It's how we look forward to the future events. And so I just want to give you a plug, as Valdez mentioned. We do have our calendar for 2025 for our events. So we have a virtual event on February 7th, and that one is going to be really interesting as well. It's about risks that we face in our daily lives in healthcare. And so we have some good moderators and panelists, but we're always seeking panelists and moderators. So if you're interested in any of these, please reach out. We have our spring conference in May. It's May 16th, and it's going to be sponsored by Peace Health in Springfield. And there we're going to have some interesting topics as well. We will be talking about basically public policy. So as we know, there's been a lot of change there. And so we have some good discussion. And then we're also going to be talking about managing morale. So that was the number one topic that was at our last event that was mentioned. And then we do have on September 26th, we're going to have another virtual event, and that'll be around behavioral health. And then October 17th is our fall conference, and that's going to be hosted by St. Charles and Bend. And then November 14th, we do have a virtual, but we do not have a topic yet. So if you have a topic that you think that we should have for November, please let us know. I'm going to go ahead and put my email in the chat as well. So if you want to reach out to me specifically, that's great. And then also, if you're interested in any of these committees, please reach out. So thank you so much. I'm going to hand it back to Tia.
Thank you, everyone. On behalf of ACHE, I want to thank our chapter leaders that planned today's session, our moderator and panelists, and of course, all of you, our attendees, for your participation. Please complete the evaluation, which is open for 1 week. I just reshared that link directly in the chat box. You can also access the evaluation by visiting your My ACHE page and selecting My Online Learning from the helpful link section on the right side of the screen. From there, click on the Access My Courses link, and you will be directed to our learning management system where you can complete the evaluation. In the same location, you will be able to access the recording of this session within approximately 2 business days. Everyone who attended today's event in its entirety will see their 1.5 hours of virtual interactive education credit posted to their My ACHE account within 2 weeks of this session in the My Education Credit section. This concludes our event, which is copyrighted in 2024 by the American College of Healthcare Executives. All rights reserved. Thank you, everyone, and have a fantastic weekend.
Thanks, everyone.